So thanks a lot. It's difficult to have the talk after the Stephen ones, but I will try. I hope you will appreciate my so cute French accent. And I apologize for every tiny error. So thanks to the faculty for this great talk, 3D planification for lung resection. Here my disclosure. First, how to do a 3D reconstructions, then indications and quick overview of new tools that we can probably use for the best option for the patients. So why we need a 3D reconstructions? I'm quite sure that you are trying to do your best to offer a minimal invasive option for your patients. So you will probably agree with me that there is a lack of overall visions, either by rats or by VATS, that you can't put your hands inside the thorax, that sometimes it's difficult where there is some unusual anatomical landmark, like, for example, intersegmental plane, if you have no ICG injections. So the preoperative study will probably help us to prevent some surprises during the operation. It's just like if I try to explain you why you prefer a map and the Google Street Vision, for example, if you are quite lost somewhere else. So that's the similar option coming from the CT scan to a 3D reconstruction. So how we can offer that for the patients? You can try to use some homemade 3D reconstruction, the PACS tool that you have in your hospitals, the Fuji or Synapse system that I put inside the homemade options, or you can try to build a partnership with some professional society that could do the 3D reconstruction for you, that there is so few words materialized in a side visible patients. And there is a lot of others, so I put some dots because there is a lot of others also. So PACS tools, one example, we start using these and I explain why we will move from others. Fuji systems, that pictures coming from Karel Feuty, a good friend of mine, in France, and he used a lot this system and he worked a lot on doing videos, trying to do what he called the fly plan, like if you are on a plane, preparing his segmental resection. Materialize one, we tested for my personal view, hope materialize is not there, it's not the best one. But you can navigate inside the 3D reconstruction, put the artery, the vessels, take it off, try to simulate your resection, so it's just a matter of time. Second one is inner side, is quite good. They add an option that you can just offer only the proximal part of the vessels, so you're not lost in multiple details, but if you need it, you can add the distal part of the vessel, for example, so that can be used. I'm not agree with the industry telling you that is a S6 or S7 or S8 segment. I think it's our own responsibility, so I was not quite good with these pre-op work. And we are using the visible patient ones. It's a matter of meeting someone, so we meet this great society that is working in France, so it was easier for us, and it's a very, very great tools where you can navigate inside, put the tumors at the margin, simulate the resections at the vessels, and navigate during the operation with this. You can plug it in the intuitive platform, for example, if you are a robotic surgeon, so there's a lot of advantages. How to choose? I mean, you have some pros and cons, so it could be time consuming if you are doing your own 3D reconstruction with your 3D console, and also it's time consuming for your radiologists when you ask them to do it for you. That's what they say to us. You need to find a way to be very confident with the model. You need also to think about injected CT scan or not. For example, visible patient is nearly to release 3D models without injection, and is a very great one. You have to think about anatomical labeling, like I said, and if you can use the 3D models for doing something else than only see the anatomy of your patients, and we all know that sometimes it's just also based on financial model. So little story that is for Stephen, because I've been very touched by what he told us last year at the Subglobal conference in Paris. It was just, what is the indication for 3D reconstruction? And he told us the story of the 3D department in the Mayo Clinic that came first with some very clinical difficult cases, like these twin sisters that was needed to be separated on, and where they try to draft the anatomy, and at the end they try to print the anatomy, and all the surgeons was around that before the operation, because they needed to have a really precise planification. It was the life of the twins that was engaged. And I think sometimes the life of our patients are also engaged in lung cancer resection, and that was successful. So sometimes it is all about surgeons' needs. What do you need in your OR when you want to do lung mitropulmonary resections? So our evaluation was that when we have no experience, we don't need a 3D reconstruction. But when we start with the segmental resection and anatomical segmentectomy, we think that we need to have 3D anatomy assessed before the operation to have a precise planification. So we had the radiologists to do with the Backstools 3D reconstructions. And after we feel that we were the best, we have the experience, we know the anatomy, even at the segmental level, and say, okay, no more 3D reconstructions. Everything is okay, but not. Everything was not okay. We were in trouble inside the operating room. So at that time, we say, okay, we get more experience, and we came back to 3D models. And at that time, we said, okay, it's time-consuming. We need it. So just let's do it with someone who will send us a very reliable model that we can use during the operation. And now we are using more immersive tools. So what could be the indication? So I know that we are in the lung cancer session, but you can use it for complex mediastinal tumor. You can use it for malformations. You can use it for sequestration, for example, to see where the systemic artery is rising. You can use it for bronchiectasis to try to spare some parenchyma. Do I need to do a lobectomy? No, I can spare a segment, for example. You can use it for abnormal venous variations. And you can also use it for segmentectomies, and that's the mainly use that we have in our institutions. So there is what we can call a standard anatomy, but what usually I say to my patient is that everyone is unique. You probably have a different anatomy than me. I will ask for you for 3D models. And just a few months ago, there come these SCTS recommendations with some key points on technical standards of segmentectomy, where one of the first key points were it's highly recommended to do a 3D reconstruction before going to a segmental resections. Also some frozen sections. I love these frozen section on margins in lymph node because it can be provocative. ICG for ISP delineations and others recommendations. So why we use this one? Because there is an almost perfect concordance between what you see during the operations and what has been predicted by the models. And that's very important because sometimes even with a model, you can be lost during the operation. So you need to fit to your models, knowing that the model is right and that you perhaps have to push further your dissection to find the vessel that you are not seeing at that way. That's why preoperative 3D models does not prevent from an adequate exposure. That's not because I have a great planification that I don't push further my dissections. And it's really, really helpful when you have, for example, this anatomical variation with the head 3 segments on the left side where the artery come from the common trunk with the lingular arteries. So what is our experience? So we first, at the first year, we were doing segmentectomies only for compromised patients, the one that could not tolerate lobectomy. But since now we are more in an intentional way for all patients with a tumor less than 2 centimeters peripheral. And what we've seen when we have a quick overview in our database is that we had a big change in 2015. And what happens in that year? 2 things. We get 3D models routinely for all segmentectomies, and we buy the ICG. And we see that we have a huge steps, and we were doing more and more complex segmentectomy that we were not doing before. So just a quick overview that we have tried all segmentectomies. And it's not also to see the vessel, it's also to have a better planification of the margins. And that's very important to determine which segmentectomy is the one. Like said Stefan, not to try to fit one patient for one segmental resection, but to adapt. This tumor is on that segment, but perhaps very close from an intersegmental plane. So I will have to do a B-segmentectomy, for example. So for here, a little tumor that you can do a lingula plus S3 or a S3 plus S4 segments. And it could be for the same tumor, depending on the patients, the anatomy of the patients. Here, for the lower lobe, it was very, very helpful to help us to determine, for example, a S9 plus S10 segmentectomy that could usually be very difficult without, because we want to be sure of our margins and not to come with invaded margin that could provocate local recurrence. And also we asked the model to try to give us our functional evaluations to estimate what would be the loss and what would be the percentage of healthy lung remaining. So not only based on the volume, but also based on analysis of healthy lung, meaning emphysematous part of the lungs will be also evaluated. And as for pilots, we usually do a lot of comparison between surgery and trying to take care of a plane. I think we also have to think about simulations and have a flight plan in our head. And what are doing the pilots before their flight? I think I asked the residents to do the same. For example, we are planification. The planification is a S1 plus S2 segment, and he has to tell me, okay, first A2, second B2, and the way in which he will treat each vessels. And that came from that 3D reconstructions where when you have done the steps, you can use the 3D reconstruction to clear the vessel that you have cut, and you will have the vision of the next step to prepare, and that's very helpful for educations. Also for educations, you can use some immersive tools like the HoloLens mask, and it's more virtual reality. And for example, in the robots, where you do not have the 3D reconstruction plug in the robots, you can have also the mask and try to see what happens on the model. So it's just like I'm a clown, but in fact, I'm doing that. I'm trying to get the models, turn around the models, add the vessels, and confirm the anatomy that sometimes I'm doing during the dissection that I'm doing. And there's a lot of publications coming with these 3D models and what we can use with the 3D models, like sharing during our staff meeting with the others to explain why we want to do this segmentectomy, sharing during inside the operative room, also sharing with the junior for their educations, with a lot of playing games where they will be very aware of the anatomy, and sharing with the patients. And the patients love to have the printed models and to have explanation with them and say, oh, that's your tumor, see there's this vessel and I'm planning to do this segmentectomy for you. And sometimes we say, okay, we want to be sure that it's a better post-op recovery. How can I afford that models in my hospital? So I like these publications where the little thing at the end is that they prove that you have a cost effectiveness if you use the 3D models. Do we need a 3D printing? Sometimes I feel that I feel better. I'm not sure of that. I just think that for some cases, complex mediastinal tumor for education or even for the surgeon, it could be helpful, but not for all patients. So we are not doing it in a daily routine activity. But what we are quite sure is that probably using this technique will be the daily practice for all thoracic surgeons. So in conclusion, 3D reconstruction is part of what we can call thoracic image-guided surgery. There is some SCTS recommendations if you want to address segmentectomies. It's helpful for training and educations and allow patients to be involved in. I can't finish without a great thanks to Dominique Gossot, who was one who sent the programs, started the VATS thoracic surgery in France. So, and all my best teams, because everything is nothing without them. Save the date for the next sublubar resection conference. Will be joined with the bronchoscopic ablation summit. So I think it could be a great event. Thanks, everyone.